Whether you are joining us for the first time or returning, we're glad to have you here. In previous series, we've discussed diagnostic criteria and assessment and management strategies using case studies to illustrate how patients with infection-associated chronic conditions may present in clinical practice. This new series builds upon that foundation, offering practical tools and guidance you can immediately apply in your work. With over 17 million people affected by long COVID, many of whom meet the criteria for ME/CFS, collaboration is essential to supporting this growing patient population. So again, thank you for being here. To foster engagement, we encourage active participation. Please take a moment to introduce yourself in the chat, share your name, practice location, and area of focus. It's just nice to get to know one another. As I mentioned, this is a shared learning space, and so your insights are just as valuable as those shared by our lecturers and our mentors. So please feel free to participate at whatever comfort level you have. To kick off today's session, I'm excited to announce and introduce Dr. Zeest Khan. But before we begin, I want to go over a couple housekeeping items. Today's session will be recorded, but all participant and patient information will be edited to ensure privacy before the recordings are made available. You can find those recordings on Bateman Horne Center and the University of Utah's Project Echo websites, as well as our YouTube channels. Following the session, Sarah will send out an email with details on how to claim your CME and access Dr. Khan's slides. Please remember to claim the CME by midnight tonight, and the best way to do it is through the call-in option. To preserve Dr. Khan for the Q&A and discussion, we pre-recorded her presentation, but as you can see, she's on the call with us. So as we move through the session, feel free to submit any questions or comments in the chat, and I will share these with Dr. Khan and our mentor panel following the conclusion of her presentation. I want to give a quick acknowledgement to the mentors for this forum, which include Dr. Braden Yeoman, Dr. Lucinda Bateman, Dr. Melanie Hoppers, and nurse practitioner Jennifer Bell of the Bateman Horne Center, and Dr. Jeanette Brown and Dr. Clayton Powers of the University of Utah. I'm very excited to kick off this new series, and I'm so glad to have you all with us. I'm going to go ahead and share the recording. And again, feel free to enter any questions or comments in the chat, and we'll address those during the Q&A.
Happy 2025, everyone. Let's talk about navigating clinical uncertainty in long COVID. I am Zeest Khan. I am an anesthesiologist in Northern California. I've been away from clinical practice for the last few years because I myself have been struggling with long COVID. For the last year, I've produced a podcast called Long COVID MD, where I help patients understand their symptoms and help patients and hopefully healthcare workers identify ways that we can match our existing healthcare resources to the specific needs of people with long COVID. We're going to be talking about uncertainty today. It is not a character trait of medicine that we are comfortable with, nor is it one that we have been trained well to navigate. In medicine, we are used to finding absolute answers for clear questions. But uncertainty is unfortunately the name of the game when it comes to long COVID, at least here in January 2025. And I want to talk in this next half hour about ways that you as a clinician can continue to help your patients even when all of the answers are not immediately clear. I have no disclosures. And the objectives today are threefold. One, to help identify challenges to care for patients with long COVID, identify challenges to clinicians who are caring for people with long COVID, and hopefully to describe some strategies to improve patient outcomes and clinician confidence when taking care of people with long COVID. This is my journey in pictures. Ever the optimist, I'm given thumbs up in my anesthesiologist scrubs on the left and my patient hospital gown on the right more recently. In the middle is a picture of me in an operating room in 2020. I was awaiting a patient who had been hospitalized with COVID who required lung surgery. This was the first and only time I had access to a PAPR. I, like perhaps many of you, live in an area and work in an area that does not have unlimited economic resources. Protective equipment was limited during those early days. And ultimately, I wasn't able to wear the PAPR for the lung case because I needed access to my ears in order to ensure that the patient was intubated properly. If you have insight into lung surgery, you know we use a specialized endotracheal tube that isolates each lung. One of the ways we confirm location is by listening. So I took off my PAPR in order to best serve the patient. I share this to acknowledge that we as healthcare workers have sort of been through the ringer, and we have certainly been exposed to this infectious agent. I am not the only healthcare worker who has long COVID. And I encourage you, if you're having symptoms or you see a colleague having symptoms, to pursue treatment. So now I have interfaced with healthcare in two major ways. One, as someone who delivers healthcare, and now as someone who is receiving healthcare. And I will tell you, it is much more fun to be a doctor than it is to be a patient. But I have gleaned some valuable insight over the last few years, and there's a couple of things I want to highlight about the patient experience when patients have long COVID that I'd like you to keep in mind before you see your patient. One is to recognize that there is an inherent and quite strong power imbalance between patients and providers. It can be easy to overlook or underappreciate. I was very surprised at how nervous I would get speaking to my provider, even those who I know are kind and have an excellent bedside manner. You as a provider are the gatekeeper to resources, and we unfortunately have gotten to a point where many patients with long COVID, because they have to interact with the healthcare system so often, start thinking about ways to convince their providers that they should be believed and that they deserve care. Patients should not have to perform for us, and yet that's unfortunately part of our current structure. So I invite you to keep that in mind, just how vulnerable patients are before you even see them. Secondly, part of that vulnerability is compounded by the logistical struggles of getting to you in the first place. This long COVID is a fatiguing illness, and oftentimes getting to medical appointments uses all the energy that the patient has for the day. What looked like molehills to me in 2019 really looked like mountains, and were mountains after I fell ill. So by the time I got to my medical appointment, my fatigue was so significant that it compromised my ability to communicate. It exacerbated my cognitive impairments or brain fog, and it made it even more challenging to communicate effectively with my clinicians and made me feel even more vulnerable. So I invite you, as you knock on the door to enter the patient's room, to keep these two characteristics or these two ideas in mind. Of course, patients are not the only ones in that medical experience. Clinicians also face some unique challenges when caring for people with long COVID. First and foremost, there is an unfamiliarity with this disease process. Even if you are someone who keeps up to date with long COVID research, we still don't know everything. And it is a unique situation or a special situation that we are caring for people when we don't quite know what the answers are. There is a legitimate and valid fear, perhaps unique to the United States, for medical legal repercussions for prescribing medications or treatments off-label. Currently, there are no FDA-approved treatments for long COVID specifically, so treatments or prescriptions can be off-label by default. This patient population, as I said, has interfaced with healthcare numerous times and has had a spectrum of experiences. People with long COVID are still ill, and that means that healthcare has not met their needs. And so there can be significant frustration on the patient's side, which also leads to distrust. And that is an obstacle that needs to be overcome when you, as a provider, are building a relationship with your patient. And then I think it behooves us to acknowledge that we as clinicians might feel like we have failed our patients when they don't improve. And in this presentation, I want to suggest ways that we can reframe the concept of treatment failure so that it does not discourage or impede us from continuing treatment. Our existing healthcare model works pretty well for many disease processes, but does not work so well for people with long COVID. What do we typically do when we see a new patient? We talk to them, we listen to them, we assess them, and then we identify patterns in their symptoms. Using those patterns, we create hopefully a short differential diagnosis list. We order tests to further clarify or land on a particular diagnosis, and then we provide treatment for that diagnosis. We follow markers of disease progression or recovery. This method has some holdups when it comes to long COVID. And the first is identifying patterns in symptoms. Unless you are pretty keenly aware of the ways long COVID presents, it can be very difficult to make sense of the myriad symptoms that people with long COVID present with. The next holdup is testing. We do not have serum biomarkers that reliably diagnose long COVID, nor do we have tests that mark disease progression. The next holdup, of course, is a big one, and that is treatment. There's a big question mark after treatment. What actually works, and what can we do? As I have been reflecting on my experience as a doctor and now as a patient, I started thinking about ways that healthcare could better serve me. And I kept coming back to a line in the Girl Scouts. So in the before times, pre-2020, I was a Girl Scout troop leader for my daughter, and we taught the girls the Girl Scout promise, ways to interface with your community and the world responsibly. And one part of the promise is that I will do my best to use resources wisely. So I've just identified ways that the current healthcare paradigm does not optimally benefit people with long COVID. So what can we do? Because we do have a powerful healthcare system, even if it is not specifically designed for people with complex illness. How do we use our existing resources wisely to meet the needs of people with long COVID? Well, we need a new healthcare paradigm. We don't necessarily need to rebuild all of the resources that we have, although I am holding hope for an ultimate way of diagnosing and curing this condition. Until then, I propose that we start thinking about our resources and our role as clinicians in a new way to maximize the ways that we can benefit our patients. One of the characteristics of this new paradigm is getting comfortable navigating clinical uncertainty. If we don't have established guidelines of care and a wealth of evidence-based research to bolster or support treatment strategies, I propose that we then pivot towards personalized care or hyper-personalized care. What are the specific needs of this patient when I don't have guidelines for this group of patients? What then does this specific patient need? By answering that question, I argue you will benefit your patients tremendously. Next, I propose that we rethink our role as healthcare providers. Currently, we tend to be the ones who give information, we order prescriptions, we decide on testing, and we are the givers, the patients are the receivers. I suggest that we zoom out from our prescription pads and think of ourselves as expert medical collaborators instead. Collaboration requires a two-way street. It is going to require building a patient-clinician partnership, being open to receiving information, both from experts like those at Bateman Horne, but also your patient. In order to provide hyper-personalized care, part of that is being open to learning from our patients. Patients with long COVID are learning as much as they possibly can and appreciate when their healthcare providers are also wearing their thinking hats too. In my podcast, I talk about ways to collaborate or invite collaboration with your healthcare provider. I have advised patients when they're interested about a particular treatment or have read a particular article to bring that to their healthcare provider and ask, do you know anything about this? It's really uncomfortable when you're a clinician to say, no, I don't. And yet I encourage you to learn to be okay with that. Your patient is not going to start distrusting you when you admit you don't know something. They will start distrusting you when you are not willing to learn about something. And so I encourage you to catch the ball that is tossed to you from your patient and be willing to collaborate with them and get information, receive information, again, not only from medical specialists, but also from your patients who are quickly becoming or trying to become medical specialists themselves because they have to. They're not getting adequate care from the existing healthcare system. Next, and equally as challenging as the first two, I know these are not easy methods to implement, is getting used to trial and error. Trial and error is a really inefficient way to recover from illness, and yet it is the option that many of us are left with, many of us meaning patients with long COVID. Patients are using trial and error, and I benefited from partnering with a physician who helped me assess which treatments were worthwhile, what were my options, what was safe for me, and what would potentially benefit me. If your patient is not doing this with you, trust that they might be doing this on their own without medical guidance. Trial and error, when in partnership with a medical provider, can be safe, it can be structured, and unfortunately, it can be a slow process, which means that you as a clinician should dedicate some time and recognize this is going to be a relatively longer process, that we're not necessarily going to see immediate impacts in all of the treatments that we trial. Hopefully with some, we will. In order to utilize a trial and error approach effectively as a clinician, we need to rely on patient feedback to inform our treatment plan. And I'm going to talk a little bit more about ways to approach the decision making of trying a new treatment with your patient. How do we then, practically speaking, implement some of these ideas? I suggest a few things. The first is frequent check-ins. Our existing healthcare model does not often support adequate time for medical appointments. So an option is scheduling regular follow-up appointments and utilizing the appointments to focus on a specific symptom. Dedicate time to one or two issues, either to review treatment strategies that have worked thus far or are in place thus far, or to brainstorm about ideas for new treatments. Frequent check-ins are also going to allow you as a provider to see your patient over a period of time. Long COVID has symptoms that wax and wane in severity, and by seeing your patient regularly, you are going to increase your chances of seeing your patient when they're at their best and also when they are really struggling. And that will help you get a better idea of what their reality is and what their illness really looks like. Next, I suggest that we as providers redefine what help means. Again, let's zoom out from the prescription pad or the EHR order set. We cannot give definitive treatment for every condition a long COVID patient has immediately. Sometimes there is no prescription that we can write that can help our patient in front of us, and that is a tough situation to be in. But that does not mean that you can't help. Help can be a prescription, and it can be emotional support and practical support. And I'll talk about these in a moment. As a clinician, it can be tremendously helpful to patients to collaborate in order to tease out what symptoms or what needs are most urgent. Prioritizing multiple medical problems is a skill, and it is a skill that you might be perfectly positioned to help with. It is a skill that can be very challenging to do when you are sick, and it can be very challenging even when you're a patient who is feeling pretty well to do alone. This activity or this action has very big payoff. Next, I encourage us to communicate our treatment goals and have some clarity so that what you as a clinician expect from a treatment or consider success and failure is understood by your patient and vice versa. The harm benefit calculation that clinicians do in our own heads, it really helps to communicate that with your patient when the treatment endpoints are not immediately clear. So talk about what is this treatment? What is it indicated for? How long is it going to take for us to see an outcome? What are potential side effects that might be deal breakers for the patient? And what is our goal with this treatment? How are we going to define if this treatment is helpful and useful? How are we going to define treatment failure? Like, this isn't worth our time anymore. And speaking of that, how do we look at failure? When we have accepted that this is trial and error, it helps offset the failure that feels like we haven't rescued our patient. A treatment that is started responsibly and safely, even if it does not benefit the patient significantly, can still provide important data and information to guide our next medical decision. So I'd like you to think about treatments, even when they don't quote unquote work, as opportunities to pivot the direction of care instead of ending care and saying that you as a clinician can no longer help. If you are a primary care provider, you're not going to be able to do this on your own. If you are a specialist, you're not going to be able to do this on your own. Long COVID has multiple symptoms and that affect multiple organ systems. And so it makes sense that it's going to require a team approach to help improve our patients' lives. When you are referring your patient out, I'd like you to do so with intention. Clarify for yourself, what is the question or problem that my patient is facing that this specialist or this other clinician might be able to help answer. Referrals should be used with intention and thought, and instead of transfers of care. Even if you refer your patient to a long COVID clinic, they are not necessarily going to have all of their needs met, and they may not be able to access that clinic for a very long time. Long COVID clinics are disparate. They offer different things, and they should not be utilized, in my opinion, as transfers, but instead part of a holistic approach, part of a team effort to help improve a patient's life. And speaking of that, whether you are a primary care provider or a specialist, you have the opportunity to be a home for a patient who feels lost. Long COVID is overwhelming. I have used this word multiple times because it is so applicable. Our symptoms are sudden, severe, and multiple, and it is very hard to navigate our way out of this burning building alone. What is a medical home? Someone who is a home or a home base has the opportunity to hold information for a patient, not withhold information, but to hold that information and help guide the patient through what that information means and help them make decisions that may not be clearly the ultimate cure, but can be a safe, structured ways of approaching symptom management. Again, you can be this home base as a primary care provider and as a specialist, both in medical and allied health fields. These lines or these branches are not one way. I encourage you, whatever your field, to build your medical team. Network with your colleagues to find out who in your network is interested in long COVID, is seeing patients who have long COVID, and share information. This, again, is about collaboration. Patients with long COVID have benefited tremendously by building communities and leaning on the experience of a group of people who are undergoing similar circumstances. The same can be true for you as a medical clinician. What are your colleagues seeing? What has worked for them? What is not working? Share what you know and be open to receiving information from others. This is not only going to benefit your one patient who has long COVID, but it's going to benefit you professionally. I don't see a way that it wouldn't. The truth of the matter is, you don't have your one patient with long COVID. You don't have your 5 patients with a post-viral condition. You don't have your 3 patients who have ME/CFS. You are going to be seeing people with complex illness routinely through your practice, and you might be recognizing signs of post-viral conditions now that you might have missed before. I had a interaction recently with a subspecialist who is actually even doing long COVID research. We had at our recent appointment, I asked him a few questions. I got some clarity on some issues, and I was offered some new ideas to pursue, including one specific referral. And I was pretty happy with that. I considered that a pretty successful appointment. And at the end of our session, he said, "I'm sorry I can't help you." And I was surprised because he had helped me. I think it is, again, speaks to this idea that we as clinicians, if we don't use the tool that we are used to using to help solve the problem in front of us, which is like a prescription pad in this case, we think we're not helping. But sometimes we feel stuck as clinicians, and you might not know how to help. In that scenario, I suggest you think about 3 categories. How can I help this patient improve their body, their mind, or their activities of daily living? Helping their body might require some medical interventions, but it could also be immediate or stabilizing interventions like to really help a person in a crash or a time of crisis. I'm thinking about things like IV fluid hydration or short-term medications that might just be able to get this patient comfortable. There are so many amazing medical professionals in our existing healthcare system who can really help your patients. I have benefited tremendously from occupational therapy, different types of physical therapy, and several types of speech and language pathology. How can I help improve my patient's mind? And I just use the word mind as shorthand for emotional resilience. I'm going to say it again. The experience of long COVID is overwhelming and takes a significant toll on a person's mental health, not only on the patient, but also on their caregivers. What in your toolbox might be able to help bolster your patient's emotional resilience or their caregiver's emotional resilience? This disease requires emotional resilience because for many of us, it is not just a marathon, it is an ultra run. It's hundreds and hundreds of miles over a long period of time. And with any sport like that or endurance sport, there's a mind game that needs to be strengthened. And next, activities of daily living. How can I help this person's day-to-day functioning? Please keep in mind the value of disability resources, accommodations in the home and the workplace. If you don't know already, long COVID patients are at extreme risk of it impacting their employment, which then, of course, has implications for their housing stability and their families. What kind of disability or entitlements can I help this patient access? We can talk with our patients about pacing strategies, review ways that they are using their energy. What patterns can you help them identify that might be able to have a successful intervention? And then sometimes just sitting with your patient and brainstorming, reviewing what has worked and what hasn't, can be a way to help. At this point, I'd also like to point out that if your patient is using or dependent on insurance-based healthcare providers primarily, there may be opportunities to utilize healthcare providers outside of insurance that are good good investments for the patient. I'm thinking about IV hydration services that don't require a visit to the emergency room or to urgent care, phlebotomists who might be able to come to the patient's home and draw labs, nursing care, help with household chores, again, accessing help that can help improve this patient's daily life so that they can focus more on their physical health. There are, of course, challenges to all of the suggestions I have offered today. We've talked about the short appointment times. Insurance prior authorizations are a big source of frustration for patients. Right now, we are particularly limited because many treatments that look worthwhile do not yet have FDA authorization, and so many insurance companies won't cover them. There are long wait times to access medical care, whether you have long COVID or not. I want to take a moment to talk about these last two things. Patients can be very distrustful of healthcare workers, sometimes rightly so. And there is a plethora of information online about long COVID, some of it valid, some of it questionable. And it makes me very concerned again about patient safety and makes the need for medical collaboration with someone like you even more important. So your patients are going to go online. They have been going online and they have been doing online research. Sometimes these resources are valid. Sometimes people online are selling magic cures that are not helpful or potentially harmful. I encourage you to ask your patient, what have they been looking at? What are they interested in? What have they heard about? And guide them to trustworthy websites, podcasts, and experts who you have a little more confidence in. Again, it's also an opportunity to catch that ball and do some research on your own about treatments that your patient is thinking about. I have done a whole podcast episode on ways to spot disinformation about long COVID. I encourage your patients to foster positive online interactions and think about ways that social media in particular is benefiting them or conversely is adding to their stress. We want our patients to feel supported and not as afraid. There are some reliable sources of education online, and the Bateman Horne Center, of course, the Foundation for the National Institutes of Health, I have found to be quite helpful. The Workwell Foundation, Recover, of course, and then I've inserted a QR code to my Substack website. As we wind down here, I want to remind you that you as a clinician can help your patients, even if that help does not look the way that you are used to. You have a big toolbox of resources, and I encourage you to start using those tools in creative ways. Embrace a collaborative, patient-centered approach to care with a person with long COVID, because that is going to help lead you to some answers when there is a paucity of answers for this field in general. Focus on being adaptable, remember to keep learning, and encourage your colleagues to join you in this journey. There is a wealth of information and wisdom in this large healthcare group that we have, and we can learn a lot from one another. And with all that, if we keep an open mind and practice with safety, those two things together, I think, are a combination that is going to set you up for success when caring for your patients with long COVID. I want to thank you so much for having me and listening to my input. Thank you so much.
Dr. Khan, thank you for that lecture. I think it goes without saying that in this time of uncertainty with long COVID, with ME/CFS, all of these post-infectious diseases, that we sometimes need permission to ask for help, to look for other resources, and to know that it's okay to not know the answers. And so I love seeing so many people on today's call because it's through this network that we learn and grow with our patients together and help support one another in that process. So thank you so much for your time on that.
I am so happy to be here. I'm so pleased that I was able to share my thoughts with you. And in particular, I want to point out how helpful this accommodation of pre-recording this video was. I was able to shorten it for clarity. You guys might have noticed those quick edits, but it really allows me in a way that is simple and pretty technologically accessible nowadays to participate in conversations like this. It is a skill set itself to learn how to receive help and use it. And I think that's a muscle that I'd like all of us to flex when we're in that authority position as a clinician and when we ultimately need to receive help personally.
Dr. Brown, I noticed that you mentioned in the chat you had a question there, and I'd like to turn the floor over to you to ask it.
Dr. Khan, thank you so much for presenting. One quick comment. I just finished reading the book called The Autumn Ghost. It's written by an anesthesiologist about the polio epidemic. But, less than 75 years ago, your field and my field didn't exist. And physicians would often, and other providers would be at the bedside holding the hand of a dying patient without things to do. I think in some ways our fields forgot what that was like. And we were used to, put them on the ventilator, do the things, all the stuff, and forgot what it was like to be in those places where you couldn't fix it. I work my pre-COVID subspecialty was neuromuscular respiratory failure. So I take care of patients with ALS, which is a terminal disease. And to spend time with folks and say, I can help your symptoms, I can do things, but at the end of the day, I can't change the overall outcome is hard. But to be able to say, it's important for me I will walk with you through this journey, ups and downs, I think has its own therapeutic benefit that people forget about at times too, because we're human. I want to ask you sort of your opinion, because I'm a woman of color, if you think that, obviously long COVID impacts women, it tends to, impact certain populations as well. How do you think that impacts maybe your experience, but also those of other long COVID patients?
Thank you so much for your comments, for your work, for your reminder that there is inherent vulnerability in medicine. It made me think of a comedian I once heard who commented that people don't have final words anymore because we have so many interventions, and that experience of, I guess, acceptance, we're a little bit more distanced from it. As for, bias in medicine impacting the way that these conditions are treated, there are people here like Dr. Bateman who have been seeing this for a longer period of time. It is very easy for me to acknowledge and recognize that misogyny in particular plays a huge role in the ways that we approach women of a certain age. And that is the demographic that often presents with post-infectious conditions, fibromyalgia, which I was taught. I remember in med school having the lecture and the big slide that said, fibromyalgia is psychosomatic, we treat with antidepressants. There is maybe speaking to vulnerability, we have a very hard time in medicine accepting that we don't know something about a subject. And for some reason, it is much easier for us to then declare that this is not an organic condition, that this is not real. We use code words And patients are savvy enough to recognize what those code words are, whether you change the particular wording. So, yes, I think that misogyny is at play here in dismissing and minimizing symptoms. Men, as with everything involving misogyny, are impacted negatively by those same biases.
I'd like to ask everyone on the call, how are you navigating the uncertainty? You know, Dr. Khan, you gave us some really good tips. Are there additional ways that you are finding helpful in your practice with these patients? I mean, of course, just listening and validating, I think, is probably one of the most important steps. I would also argue that it's very prescriptive for so many of these patients. But are there other tools or approaches that you are using in your practice that are helping? Dr. Bateman?
You know, the amazing thing about this talk is that it's pretty comprehensive. I mean, it covered everything. The things that I've learned in my 25 years of practice. And I have to say that the single most important tool I have is listening and learning from patients. You know, letting my experience help them put theirs in context, right? But really partnering with patients to carefully assess and make progress. And that's such an important message. I also wanted to say that I was really lucky because I started practice before anybody knew what fibromyalgia was. And because the 1990 criteria were published the year I started practice. So I started seeing patients with an open mind and listening to them. And I learned everything about fibro from patients and from trial and error and teaching them. So it's just bizarre to me that it could be considered a psychosomatic illness, but it's just a good lesson, right, for all of us.
I think I was lucky because, part of my training was in the ALS clinic, the muscular dystrophy clinic. Very much enjoy the team approach. And I've been lucky here where I am to have the support to have speech therapists, PT, OT, and people with different perspectives and training than myself. And I often, I'm lucky enough to have a list of subspecialists too that I work with. And I think that team approach, the phone a friend, I don't know everything. When you talk to the patient, you may pick up something different, but just being able to collaborate that way and think creatively as well. And including the patient in that too. They may have noticed something. And I think that's what we're going to take away from long COVID. In 10, 15 years, we're going to talk about, patient-centered outcomes, but the original description of those studies, with the body politics study, the online stuff, is that it was truly patient solicited rather than me as a researcher or clinician saying, fill out this review of systems. It was people telling us what they were experiencing. So I actually have hope that, long COVID, in decades from now, will have made a positive impact on how we, do research in medicine. But hopefully we don't have to wait that long for more things to do for it.
So, what everyone has said already is so have just put into words so many things that I think all the time, but can't put into words so well. So, I think this was such a great lecture. I'm a provider for people with ME/CFS and long COVID, as well as a mother of a now adult daughter. She has moderate to severe ME/CFS. And one of my observations in pediatrics, I also see pediatric patients, is listening to the patient as well as the parent. And sometimes your challenge is getting the parent to understand because they're trying to take care of their child and they don't know what their child is experiencing. And sometimes it's hard for that child to verbalize him. They don't know what is going on. They don't know how to tell the parent, I need to rest. So part of the challenge with kids is to really try to do a lot of education, to do a lot of support, a lot of accommodations, and to listen to the child, to make sure that you take the time to not just listen to the parent, but listen to the child. And I can tell you that, I'm a physician and still the way that I saw my kid get treated it was so demoralizing. So just listening, and as Dr. Brown said, hold their hand through the experience. Sometimes all we wanted was a friendly face. We finally found it at the Bateman Horn Center, so they're there, but, be that friendly face. There are so few pediatric providers, and I know it's intimidating because there's not much literature in peds, and when you go to a lecture for pediatric long COVID, they say we need to do more research, and that's usually kind of the end of it. There's not a whole lot of suggestions, but there are things that can be done. So just, start slow. Don't be afraid to see kids, and certainly don't be afraid to see them help educate their family, help with accommodations and things like that.
Thank you. I love that all of you have kind of spoken about topics that we're going to specifically address in this series, which are, documenting medical disability and supports, effective communication tools. So how to break down a visit with your patient so that it is that much more effective for them and for you, being flexible, pediatrics and sleep and everything else. So you've already kind of teed this up for me so beautifully. Thank you. We have just a few more minutes, Clayton, and then we'll go to Jennifer.
Yeah, I love the points about education is therapeutic and providing multiple forms of education. I've already had 2 patients today who said to me at the end of the visit, do you have a way to send me this via email or something? And I say, yeah, we already have videos and other handouts and things. So having educational tools, not only in the visit, but also outside the visit can be super helpful. And then the other thing is, I think modeling pacing in the visit. So when a patient is describing their symptoms, and sometimes as they're talking, you can tell that they are starting to have symptoms. They start sliding back in their chair, or they look like they want to lay down, and modeling that, let's just go ahead and have you lay down, or let's dim the lights. Let's take a rest break during this discussion and just give you some time. And so being able to model that you can take some time in the visit and that it's not so rushed to get through the visit, it can be really impactful for patients.
I just wanted to agree with everything everybody said so far. I just would like to add humility. And I've been at the Bateman Horn Center for 4 years and been practicing as an NP for 30. And I think I've always been a relatively humble provider, but this has really humbled me because we don't have the answers. And I think medicine has a real arrogance right now that we have all the answers to everything. And if it doesn't fit in our present knowledge base, then it's psychosomatic, or we seem to throw it in that bucket all the time, or it's not real. And working in this environment with an illness that is so misunderstood has been just, life-changing and practice-changing. And so I think that helps me be present and helps me validate the patients. I do my best to not walk into with any preconceived notions of what's going on with this person. And I remember Dr. Bateman saying something early on when I started there, no patient would choose to live this way. And that just has always resonated with me. And so we need to believe our patients and put aside our biases and be humble when we're working with them.
Really excellent points. I think the other most important thing that I've seen through collaborations such as ECHO, clinician rounds, forums that, really foster this peer learning is that we all are learning from one another. And the more disciplines that we bring into that, the more perspectives that we have. And so we learn that much more about the patient, right? It's multi-system, so it takes all of us. And so I want to say thanks for being here today. Dr. Khan, thank you so much for such a eloquent and meaningful presentation. You started off our series perfectly. I hope that everyone got something from that today. And our next session will be on February 4th. Jamie Boots from the University of Utah's Long COVID Clinic. He's a speech therapist who will be speaking about tools for effective patient visits. And as a SLP, he does a wonderful job kind of giving advice on how to structure some of those sessions so that they are the most fulfilling and impactful for everybody. We hope to see you there, and don't forget to claim your CME by midnight tonight. Take care.
Also, I just wanted to say welcome to all of our international folks too that have joined our Echo. I think it's amazing to see the reach of this. And I love, my phone a friend list has way more exciting area codes and zip codes than I do.